have this for those who aren't able to attend. But you know, our if you think about it, our vascular system is closed, right? So if you unzipped yourself, you know, if you had the ability to unzip yourself and open your chest like you would a jacket, you would see that there's no blood circulating around in there. Everything's in the vascular system, and it's closed and it's under pressure. And what happens in your car when your radiator hose breaks? That pressure is lost and volume is lost. And eventually, if you don't, you know, recognize that your radiator hose has ruptured, you'll end up burning out your engine. And so I want you to be thinking about that's kind of what happens in our body. You know, once we have hypovolemia, all of the shock states will occur if we don't correct that volume loss. So today we're going to start with cardiogenic shock. And cardiogenic shock, so in hypovolemia, we have a volume issue. We have an issue where we don't have enough volume, and that's what affects stroke volume, and that's what affects cardiac output and eventually affects perfusion. In cardiogenic shock, there's not a volume issue. We have a pump issue. And so that is, if you look at it, that's the one state where there's really not, we don't have a loss of volume, but we have a pump issue. And in fact, in cardiogenic shock, our volume, we may have too much volume, which will back up into our lungs. And so sometimes we have to kind of get rid of some of that fluid in order to help the heart be a little bit more efficient. But in cardiogenic shock, we don't have a volume issue. It's more of a pump issue. And so the pump is not able to adequately pump blood around the body. So what happens is we end up with inadequate tissue perfusion, and then the whole process starts with the changes in cellular metabolism and things like that. So the heart is not able to supply the vital organs, which are what we consider our vital organs to be the brain and the heart. It's not able to adequately perfuse them. So some of the body always shunts the blood to those vital organs, and so the ones that are non-vital, like your skin or kidneys or lungs, well, they are vital to us, but in the grand scheme of things, if you don't have a brain or you don't have a heart, the rest of those things aren't going to function either. And as a result of that, we have all kinds of other problems that occur with our other organ systems. And so if we don't correct those problems along the way, then we end up in multi-organ dysfunction. So MODS, in other words. So this cardiogenic shock, we know that the greatest percentage of cardiogenic shock is a result of an acute myocardial infarction, and 50 to 60% of those patients that have an MI who end up in cardiogenic shock, 50 to 60% of them will have they may not survive that particular event. So cardiogenic shock is either going to be a systolic or a diastolic dysfunction. So what do I mean by that? What am I talking about? What is systolic versus diastolic? What's systolic? Let's start with systolic. What's systolic dysfunction? The heart, yeah. So
it's contracting, right? And the diastolic, it's relaxing.
It's relaxing. So you're right. In the systolic phase, that's the contraction. So that's the amount of force that's coming out of that left ventricle. And of course, our left ventricle is super important. And when you think about diastolic, you're right. We're in that relaxing phase of the cardiac cycle. But what is important about the diastolic phase besides relaxation? What's happening during diastole? Filling, right? filling. So we're moving blood down from the atria to the ventricles. All right, so that's important. So I want you to be thinking about systolic as contraction, diastolic as filling. So remember, what did I tell you that? What is the definition of cardiac output? What's the definition of cardiac output? This is something you gotta know. So remember that cardiac output is the amount of blood pumped out in 1 minute. So stroke volume and heart rate comprise cardiac output, and so anything that affects stroke volume and or heart rate will affect cardiac output. But the cardiac output is actually the volume that's ejected out of the left ventricle over a 1 minute period of time. So, theoretically, that's going to be anywhere between 50 and 100 milliliters of blood. So what is stroke volume then? What's the definition of stroke volume? You know this. So stroke volume is the amount of blood that's pumped out the left ventricle when over what period of time? Yeah, with each contraction, right? Per contraction. Very good. So those things are important because in order to understand how your meds work, you have to understand what cardiac output is. You have to understand what stroke volume is, okay? So the drugs that we're going to use are going to affect. So stroke volume is made up of these things. You guys remember these things? Preload, afterload, and contractility. Do you remember those things from a blast from the past? So stroke volume, and so the medications that we give are going to affect one of these three areas. All right. So what is preload? Who can tell me what preload is? Who knows the definition of it? It's when the ventricle is filling. It's the amount of stretch, right? So just think about it. So the blood is moving down from the atria to the ventricle, and it's filling, and that ventricle is stretching, and when it gets full enough, boom, we have a contraction. All right. So that's what preload is. It's the filling. And it's actually the stretching of that ventricle prior to contraction. So how much stretch is there? So then if we know that's stretching, and we're filling and stretching, and then boom, we have a contraction. What is afterload then? It's the pressures. It's the pressure. It is the resistance that the heart has to push against to deliver that volume. So what kind of things increase our afterload? Do you remember? Volume, volumes, COPD, things like that will increase your resistance, increase your pressure. And then obviously contractility is the strength of that contraction. So think about when you have a well-conditioned heart, you're an athlete, your contractility is really, really good, right? Because you have a strong muscle, you have a strong left ventricle. So what happens to heart rate in an athlete? Because they're so efficient at their contractility. What happens to heart rate in those type of people? It's low, right? It lowers, right? The resting heart rate lowers because it doesn't need to pump as often because it's super efficient. Now take that to a patient who has maybe cardiomegaly. What happens then? Or they have cardiomegaly, floppy heart, large hypertrophic chambers. It's going to increase heart rate. So I want you to be thinking about not just what do these terms mean, what is their definition, but how do I apply them, and what medications are going to affect preload, what's going to affect afterload, and what's going to affect contractility. So while we're talking about that, let's think about like I don't know if this is a good time to introduce this, but I'm gonna do it anyway. So what happens? Think about, what does vasoconstriction mean to you? What does that mean to you? What does vasoconstriction mean? What's the definition of it? It's going to increase blood pressure. It's when the vessel is going to narrow, right? And as a result, we're going to have constriction of a blood vessel. And as a result of that, we're going to push up blood pressure. What happens when you vasodilate? That vessel is going to enlarge, but the volume is the same. Nothing happened to your volume. So think about a patient that has hypertension. When I'm thinking about this, I'm thinking about maybe a renal failure patient who has refractory hypertension and they're vasoconstricted, and we give a drug called hydralazine. What happens to the vessel when we give hydralazine? It opens, right? It dilates. So if it dilates, what happens to blood pressure when the vessel dilates? It's going to lower. So is that because the volume went down? Is that why blood pressure? No, the vessel got larger. The volume inside the vessel, there's more room. Less pressure, less resistance, blood pressure goes down. So those concepts are things you have to, even though you've known for a long time what vasoconstriction and what vasodilation means. But now I want you to be thinking about, how does this medication, how does it work? Is it working on preload? Is it working on afterload? Is it working on contractility? All right. So theoretically, a diuretic works on afterload, right? Because it decreases the resistance because you're getting rid of some of that extra fluid. So think about, how does a vasopressor work? How does a afterload or preload? On afterload, because it decreases it can work on both, but afterload because it decreases your pressure, right? It decreases the resistance because you a lot of times have a lot of volume. Okay, so so this is something that I really want you guys maybe to download this this little image that I have up here, because I really want you, and a lot of times we just don't really understand the flow of blood, but it's super important because you have to know, how does it get into the right side of the heart? How does it leave the left side of the heart? What valves is it going through? What structures is it going through? So that you can really understand. Oh, no, but let me think about it, Carrot. I don't have a link to that, but let me see what I have on my computer, okay? Because unfortunately I'm away from home, so I don't have that file with me. All right, so systolic function, as we already said, was the contraction phase of the heart. And remember, I told you that blood always needs to be moving forward, should never be going back. So in systole, when we have contraction, then we know, if the heart is working well, that we know that blood is moving forward, and so when we have a systolic dysfunction, that primarily affects the left ventricle, right? Because remember what I told you, that the left ventricle is the strongest part of the heart. It's the biggest kick that gets blood out of that left ventricle through the aorta. And the aorta is magical in and of itself, and it sends blood to the brain, to the heart, to the brain, and then to the systemic side of things. So when you have somebody, when people have an acute MI, for example, an acute MI, do you guys know what coronary artery that is commonly called the widowmaker? You guys know what that coronary artery is? It's the LAD, the left anterior descending. Okay, it's the coronary artery that's going to feed, that sits on top of the myocardium, that feeds the left ventricle. When we have an occlusion or a severe stenosis of the LAD, a lot of times, you know, that leads to an acute MI. People die from that. They can have cardiogenic shock because it's going to affect the contractility of this left ventricle. And so it's going to, and so if the contractility is compromised, then of course stroke volume is compromised, cardiac output is compromised, and so is tissue perfusion. All right, and of course, diastolic dysfunction has to do with the filling of those ventricles. And when we have a filling problem, obviously we don't have enough blood to eject the proper amount with each stroke volume, and it's going to affect things like cardiac output. It's going to affect perfusion. So things that are diastolic in nature that can cause problems are things like a tension pneumothorax, or sometimes compression on that vena cava. Remember last week I told you that it's really the vena cava, which is the superior and the inferior vena cava, they come together, merge together to get into that right atria. But sometimes there are things that can occlude the vena cava, and that will be like an inlet obstruction, like a clot, for example, or sometimes there's tumor there. So there's lots of things that can cause cardiogenic shock. And I do have my next slide talks a little bit more in detail about some of the things that can cause cardiogenic shock. So, you know, when I think of cardiogenic shock, I think about what are the things that can cause pump failure. And I told you that an acute MI is the most common cause of cardiogenic shock, but that does not mean that it's the only cause, all right? So, and of course, an MI is going to cause systolic dysfunction. It's going to cause that contraction to occur. And cardiomyopathies can also cause cardiogenic shock. Blunt trauma to the chest, like in a car accident, pulmonary hypertension or severe systemic hypertension can cause that as well. Cardiac tamponade is an example of a diastolic issue. What else? Anything that's going to affect volume. And of course, when we get to the dysrhythmias, there are some of the brady and the tachydysrhythmias that can lead to cardiogenic shock. So remember that this stuff we need to carry over to, I think it's module number 4, when we are thinking about dysrhythmias and their effects, and also structural issues. Some of the valvular stenosis issues or regurgitation can cause cardiogenic shock as well. So who knows what a ruptured viscus is? On this list here, I have ruptured viscus. Who knows what a ruptured viscus is? Do you guys know? It's a medical emergency. Bowel perforation. So Noelle, why do you say bowel? What is it about the bowel? It's an example. It's an example of a ruptured viscus. You are correct. But what about that organ makes it? Okay, very good. So anything that's hollow, an organ that's hollow. What are your organs that are hollow? Intestines for sure are hollow. What else? Your heart is hollow. I think about my stomach, think about my bladder, think about my esophagus, colon, part of the intestines, right? So yeah, that's what a ruptured viscus is. So that's something that we don't hear too much about. So that's why I included it in there so that you guys would know what that is. So here is just the pathoflow, and I just think that it is so important. So it doesn't matter whether we're talking about what the problem is, whether it's a structural problem, whether it's systolic, whether it's diastolic, whether it comes from a dysrhythmia. The bottom line is that the same thing happens. We don't have an effective flow of moving forward. Blood always needs to be moving forward, never backwards. And we're going to see that, and you've probably already been reading about that when you're looking at your valvular heart diseases, where you can see in regurgitation, blood is flowing backwards, and you have deoxygenated mixing with oxygenated blood, and that's not a good thing. So as a result, we have a decrease in stroke volume, we have a decrease in cardiac output, and all of these things are going to lead to decrease in cellular oxygen supply, tissue perfusion, and impaired cellular metabolism. So when you look at your patho flow for each type of shock, look down here, everything ends up the same. You just need to know what's causing it up here, okay? So it should be a great visual for you, if you're a visual person, that is. Okay. So cardiogenic shock is low flow. So what is low blood flow to the entire body? When we have low blood flow, we have low cardiac output, we have low tissue perfusion, and we end up in hypoxia. So we haven't gotten there yet, but in your readings, you already know what happens in the different stages of shock. So what's going to happen? Your patient's going to become hypotensive, and as a result, we have a compensatory mechanism. The heart rate speeds up in an attempt to reach homeostasis. So our early manifestations are going to be tachycardia and hypotension, a narrowed pulse pressure, and an increase in myocardial oxygen consumption because we have an increase in heart rate. So if we increase, anytime we increase our heart rate, we're going to need more oxygen to perfuse the body, okay? I don't have it on this, I think I have it down below in the when I get to the anaphylaxis, but I want you to be thinking about what is a normal physical assessment? What does it look, what is normal when it comes to assessing the neurosystem, the pulmonary system, the cardiovascular system, the skin, all of those kinds of things so that you're able to recognize abnormal. So we know that when there's low cardiac output, low perfusion, we become hypoxic. Remember I told you that when blood is distributed through the aorta, the first place it goes is to feed the myocardium through those coronary arteries. It also feeds the brain. So, and then it feeds the rest of the system. So when our patients have anxiety, agitation, confusion, especially when that's acute, that's probably due to hypoxia. So you'll see that when we have low blood flow, you'll see your patient will have a sense of having impending doom or anxiety, or they might have confusion or agitation. They'll also be tachypnic. They may have some pulmonary congestion because remember the blood's not going to be moving forward, so it's going to be backing up. And so if you're thinking about it can't get out that left ventricle, it's going to go back to the lungs, right? And that's why you're going to have pulmonary congestion. And also you're going to have a capillary refill delay. And your skin is going to be cool and clammy, and a change in color based on your racial and ethnic background. And you'll have an increase in pulmonary wedge pressure. And usually that's about an increase of 18 millimeters of mercury or greater when we're talking about an increase of pulmonary wedge pressure, which is on that left side of the heart. Remember, we're looking at the wedge pressure in the lungs. And normal is between 4 and 12. And sometimes your patients will have increased JBD, for example, and they may have a CVP changes as well. And then they'll have, and of course, those vital organs that I talked about were the brain and the heart. But the non-vital organs are things like the skin, the kidneys, the lungs. That's what the body considers to be liver, if I didn't say that. The body considers to be non-essential, but we know that for normal functioning, it's really, really important. So, so when we have a decrease in cardiac output, we know that there's going to be weak peripheral pulses. I already told you, a delay in capillary refill. And what's going to happen to, did we talk about cardiac index last time? Did we talk about cardiac index the first time? I don't think that we did, but remember that cardiac output is the amount of blood that is more global. Cardiac output is global, and it's the amount of blood that's pumped out of the left ventricle over a 1 minute period of time. But when we're talking about cardiac index, we're talking about cardiac output, but it's specific to the patient because it takes into account body surface area. So it is more specific. So of course, you know, you have to think about your small patient versus your average patient versus your larger patient. And of course, we talked about how cardiac output would be very different in those types of patients. So cardiac output index is what you're going to see when you're in the unit and you're looking at the hemodynamic monitoring. You're gonna, and a patient that has that's in cardiogenic shock will have a cardiac index of less than 2.2 liters per minute per meter square. And meter square is, of course, your body surface area. I don't know if you guys know that or not, but that's just, that's what cardiac index is. You guys know what body surface area is? Height and weight, height times weight divided by 3,600, and then the square root of that. Probably not. But just so you know, it's just a little bit more detailed. So, okay, but you know what? I'll include that when we get to our cancer section. But here I want you to know that there's a lot of things that is important to an individual based on their height, based on their weight. So here we're talking about cardiac index. When we get to cancer, we're going to be talking about the calculation of drugs based on body surface area, because, you know, depending on what your size is, your dose would be different than my size, for example. So it's not one size fits all. That's my favorite thing to say. It's never one size fits all. It should always be tailored to each individual patient. So what will happen? What are the cardiac markers that I'm thinking about here in this slide that I'd be concerned about? No, but you have to understand the patho to be able to answer the questions. So cardiac markers, what are the cardiac markers that I'm thinking about for cardiogenic shock? What cardiac marker? Okay, so I have BNP here. That's that you're right about that. But what is this one? This is troponins. Okay, this is troponins, and troponins are released whenever the cardiac muscle is damaged. Okay, whenever the myocardial cells are damaged, the myocardial cells will release a substance, and we measure it in the form of troponins. So our troponins in these kinds of patients are going to go through the roof, just like they would if you're your patient. And of course, these patients, a lot of them are going to have an acute MI. What is BNP? What is BNP? Why do we measure a BNP? And you should remember BNP for heart failure. So you know that it's associated with heart failure, but Alice, what is BNP? Why do we have it? So in heart failure patients, we usually have a lot of volume, right? In heart patients, we have a lot of volume. So BNP is released when we have an increase in that volume for the stretch of those ventricles, okay? For the stretch of those ventricles. So preload, when our preload is really high, our BNP will be high, all right? So that's how you kind of know a lot of times the status of your patient and the volume status when you have a BNP level. Glucose levels will also increase because whenever patients are in stress, under stress, whether it's cardiogenic shock or any other kind of acute stress, the body's stress response is to secrete glycogen from the liver and the stores of glycogen from the liver, and that will increase serum glucose levels. So even in your patients, you know, sometimes you're like, oh my gosh, why are my blood sugars so high in a non-diabetic patient? That's because the body is under stress and the liver is converting glycogen stores into glucose to help the body. I didn't put here serum lactate, but I want you to be thinking about serum lactate. I told you last week what a normal serum lactate is and what the definition by numeric definition of lactic acidosis is. Do you remember what that is? What is a normal serum lactate? Less than 1, right? Less than 1, okay? And lactic acidosis is defined as a lactic acid level greater than 4, all right? So less than 1 is normal, and then we're gonna, you know, as your patient becomes sicker, you'll see that number go from 1 to 2 to 3, and then once it reaches 4, we know that that's lactic acidosis. Your BUN and creatinine, or your BUN will increase because you're holding on to sodium and water. So your BUN will increase, your creatinine will increase as well. You want to be checking an EKG in these patients because more than likely they're going to have some type of dysrhythmia. An echocardiogram. What is an echocardiogram? An EKG. No, not an EKG, an echocardiogram, not an EKG, not an ECG, an echo. Echo. It's an ultrasound. It's a picture of the heart, and it's an ultrasound view of the heart, and and it gives us our ejection fraction. It gives us the percentage, the estimated percentage of blood that's coming out of that left ventricle, and that's like really important. It also gives us insight into how well the heart is pumping. It also gives us insight. We can see the valves there. So it's a really good non-invasive tool that shows us the structure of the heart. So, you know, you can plan on getting an echo on these patients. And then of course, a chest x-ray. Why do you think that we get a chest x-ray in a cardiogenic shock patient? What do you think you're going to find in them? Pulmonary edema. Yeah, not oxygen in the chest, but pulmonary edema, because who said pulmonary edema? Who said pulmonary? Okay, so unmic yourself and tell us why you said pulmonary edema.
I believe that's a great question, Professor. I've been doing a lot of studying. So heart failure, it's got to have heart failure has lungs involved, which is edema, right? Left side, and then chest X-ray will make sense. You know that chest has lungs in it, so.
Okay, very good. And I'm glad, and you know what, I'm not trying to put you on the spot, but I want you to know why you said pulmonary edema. So let's go back to this. This is why this is important, right? So remember I told you that blood has to always move forward. But if my pump is not working, everything's going to move backwards, right? It's going to go back. So where is it going to go back to? It's going to go back to the lungs. So you're going to have pulmonary edema. And so you are exactly right. So what else will my patient display? If your patient shows pulmonary edema, shows fluid in the lungs on chest x-ray, how will your patient present to you? What will you see in that patient besides it on the film? crackles, shortness of breath, frothy sputum, right? So that's how you're going to know, because fluid does not belong in the lungs. If there's fluid, that means that we cannot exchange oxygen and carbon dioxide very well. So your patient's going to, so let's just take that a step further so you guys know what you're going to hear, right? Your patient's going to be tachypnic, they're going to be dyspneic, they're going to have crackles or rails, they're going to, what else did you say? Well, pulmonary congestion, yeah, but I want you to tell me, what will you see with a patient could have S3 MOB. When you talk about pulmonary congestion, yes, we're talking the global picture here. The question is pulmonary congestion, but what will the patient exhibit if they have pulmonary congestion? And you just told me. So now take that a step further. You told me that they're going to be dyspneic, tachypnic, they're going to have crackles, they're going to be coughing, they might have frothy sputum. Now take that a step further. What's going to happen to their oxygenation, and how are you going to know? It's going to decrease. How are you going to know? Low saturation. So we're talking about SpO2 when we're talking about O2 sat, right? SpO2. So the pulse ox, right? How's another way that you would know? We're talking about lungs here. We're talking about lungs. So SpO2 is your pulse ox on your finger. All right. What's another way you would know that they're poorly oxygenating? Blood gases, right? Blood gases, all right? Blood gases, all right? So I want you, so when we're talking about, right now, I hate to compartmentalize, but sometimes we need to, because we need to be thinking like, how do you say it? Am I right, Zahir? Did I say it right, Zahir? Yes. Okay. Okay. So tell me how to say that. Tarek? I want to be able to say your names properly if I don't know them.
Well, so the real way is Tarek, but here there are two ways. It could be Tariq or Tyreek, whatever,
Okay.
whatever is easier for you.
You tell me. Tell me again, Tarek?
Tariq is fine. Yes, that's
Tariq. Okay.
pretty standard.
Right. I'm going to remember that. Okay. And if I don't, you correct me. Okay.
Yes.
So he told us that we're going to see pulmonary congestion. And so sometimes we know these terms. For example, earlier when I was talking about vasodilation, you guys know what vasodilation is, but I want you to be thinking a little bit deeper than that. What is vasodilation? How is it going to affect your patient's blood pressure? What is pulmonary congestion? How is it going to affect your patient? What are you going to, if they're going to have, definitely they're going to have an increased pulmonary wedge pressure. And Tariq, what is that number going to be higher than?
It's going to be higher than 40 because standard is 40, right?
It's going to be 18. So standard is 4 to 12. So it's going to be higher than 18. Okay. So very good. That's how you critically think, guys. That's what I want from you. You know what, if you know it's pulmonary edema, you know that there's pulmonary congestion. What is my patient going to look like? And then if my SpO2 is low, let's say your SpO2 is, I don't know, let's say it's 88. What are you going to do? How are you going to support your patient? That's one way. What's the first thing you do? What's high Fowlers? Thank you, Mo. You're going to sit that patient up first. Why do we sit them up? Tell me why you sit them up. Why?
Because it allows oxygen to the chest properly that way. And the patient can be properly that way.
Yeah, you're going to create expansion, right? You can't lay down. If they're laying down, you know, they're drowning, right? So you want to sit them up to increase expansion, take the pressure off and expand. So you guys go home and when you get out of here, go lay down and take a deep breath, and then sit up and take a deep breath and tell me how that feels. So I want you to be thinking this way. This is what I want from you. Okay, so you're gonna sit them up first, and then you're gonna support them with oxygen. And depending on how well they saturate with your intervention, so what would be your first intervention? You're gonna give them oxygen, but how are you gonna deliver that oxygen to them more than likely? What's the first thing we do usually? A nasal cannula. And then if you're not saturating well with the nasal cannula, then you got to move up, okay, to a mask, maybe to a simple mask, then to a what? A non-rebreather, 100% non-rebreather. And we're just going to keep moving up. I mean, of course, it depends on your situation of your patient, but that's how I want you to be thinking. Does that make sense to you guys? Okay, good. Okay, that's how we start putting it together. You know the moving pieces. Now start putting it together. Now, you have a patient that's in cardiogenic shock. How are you going to correct the problem? Okay, we know it's not a volume issue. We know it's a pump failure issue. So you're not going to correct it, but what's medicine going to do to correct it? You might be given medications to help, but how are we going? What's our goal? What's our goal for these patients? Our goal is to restore blood flow, right? Is to restore blood flow to the heart so that we can balance, so that there's no oxygen. We can balance the need for oxygen and the amount of oxygen. So depending on what the problem is, the underlying cause of cardiogenic shock, we need to fix that issue. And sometimes it can be, I'm going to say, as simple as taking them to, it's not simple, but as simple as taking them to the cath lab and stenting them, right? Stenting the vasodilators. Yes, you can use vasodilators, but usually, like I tell you, it depends on what the situation is. But we definitely would need to take these patients, if they're stable enough, to the cath lab so we can determine. Wonder if it's one of the coronary arteries. We have to revascularize that area, right? So sometimes it's as simple as taking them to the cath lab. Sometimes it's as difficult as transitioning them, Mo, from the cath lab to the OR for an open heart surgery, because we need to, it's more complicated than what can be done in the cath lab. So our goal, if it's a pneumothorax, we want to decrease that pressure, so we want to inflate that lung, right? So you have to think about whatever the problem is. Is it a tension pneumothorax? Is it a cardiac tamponade? What is cardiac tamponade? Who knows what cardiac tamponade is? What's tamponade? Okay, it's compression from what? What's being compressed, Alice? Fluid. Fluid is, and we're going to talk about it, fluid that is accumulated in the pericardial sac, okay? So we're going to get to that in module number 3, where the pericardial sac it's a very fibrous, thick sac that holds the heart and stabilizes it. There's many things that it does, but fluid can accumulate in there. And if it accumulates in there, then the heart cannot pump effectively because there's fluid that's taking up space. So we got to get rid of that fluid, for example. That would be another way of correcting the issue. It just depends on what the underlying cause is for cardiogenic shock. But the thing that we want to do is we want to reperfuse the area. We want that heart to be reperfused. We want to be able to get blood out of that left ventricle to perfuse the body. So we always want to increase cardiac output, stroke volume and cardiac output. And sometimes somebody said, I don't know who it was, said that we can give medications. Yes, we'll give medications that will manipulate either the preload, afterload, or contractility. So look at those meds. And I don't know if I have them on this slide, but we're going to talk a little bit about that. Also, remember that these patients will need ventilatory support. So they're going to need oxygenation, but most of the time they're going to need ventilatory support. So a ventilator, because they'll end up in respiratory failure. So that's why I was going through, like, what would you do? Set the patient up. You might go from nasal cannula to intubation. It just depends on the situation of your patient. And also, so this is a situation where we talked about blood flow. We talked about pulmonary congestion. So how can you mitigate that? What drugs would you use to mitigate that extra fluid, that congestion in the lungs? What would you do for that? You would give, okay, so diuretics. So when we're talking about meds, I want to try really hard for you guys to don't give me drugs like Lasix. What is the generic of Lasix? Furosemide. Why do I want you to give me generic drugs? Why do I want you to be thinking generic? Do you know? No. NCLEX is only yes, Racine, NCLEX is only going to give you generic drugs. So if you don't know that the generic of Lasix is furosemide, you're going to be like, I've never seen that drug before. So in this course, and sometimes I'll tell you, sometimes I slip and say something. Yeah, learn something new, yay. So be thinking generic, okay? Be thinking generic. And then monitor your patient for signs and symptoms of reperfusion. So you know what they look like when they're hypoperfused, right? We talked about some of the signs and symptoms, what your patient's going to look like. But once you start the revascularization, you start giving some medications, your patient is improving, what will they look like, okay? What will they look like? Warm, their skin will be warm and pink. They'll have 92% higher cap refill. Better oxygenation, they'll have an improved cap refill, better oxygenation, urine output will be improved, respiratory will improve, right? So as the pump begins to improve, the overall tissue perfusion will improve. So what does that look like? And I do have a slide here. Okay, so we're going to do hemodynamic monitoring, which we're not going to talk a whole lot about in this course, because remember, yes, blood pressure will improve, because hemodynamic monitoring you're going to get when you go to S2. The MAP will improve, central venous pressure will improve respiratory rate. So these patients are going to, at the bare minimum, need a central line. Okay, these are going to be patients that are going to be in the unit, and they're going to be monitored. They're going to have a central line. So then we need to talk about drug therapy. So look in Lewis, look at what are your nitrates. You know, we know that they're nitroglycerin. We know that there's nitroprusside, which is IV. Those are the medications that are used to dilate coronary arteries. You know, we don't talk a whole lot about coronary arteries. I don't know what you guys know about the coronary arteries, but my goodness, without those coronary arteries, the heart is going to get its dose of oxygenated blood first. That's what comes right off that aorta. It's going to feed those coronary arteries, because they're like super important, because they feed the engine, if you will. So think about the drugs that dilate the coronary arteries. They reduce preload, diuretics, also to reduce the preload, vasodilators reduce the afterload, and then the beta adrenergic blockers to reduce heart rate. What are some beta adrenergic blockers? What do I mean by that? They reduce heart rate and contractility. Things that in LOL, yeah, metoprolol. Yeah, we also can use another class of drugs, but for this we're going to talk about the beta blockers like metoprolol, which is really the drug of choice. And then what is a circulatory assist device? Do you know what that is? What some of those devices are? The intra-aortic balloon pump. Yeah. No, that's STDs are, what do we use STDs for? Sequential compression devices. What do we use those for? Even though that's a great thought, venous return, right? For prophylaxis for DVT and blood flow. But here I'm talking about cardiac circulatory assist devices. Sometimes we'll use the intra-aortic balloon pump. An ICD is also, or an LVAD is also an implanted device that will help your patient to improve left ventricular function, for example, until the patient can get to the next level of care. Sometimes they might need to have a heart transplant, and they'll have some of these devices that will help. So think about circulatory assist devices. That would be like a last ditch effort for these patients if their heart muscle is destroyed. They may end up in a heart transplant. Okay. So let's talk about one of the distributive shocks. So what are the two distributive shocks we're going to talk about? Do you know? Under that umbrella? Septic and anaphylactic. Septic and anaphylactic. Now, neurogenic is in the distributive family, but you're not going to talk about we're not going to talk about neurogenic. You're not going to talk about neurogenic until you get to S2. So please don't forget this stuff, because it's going to come back to you again. Okay. So in anaphylaxis, what is the underlying pathophysiologic problem? Not the cause, but what pathophysiologically, what happens in distributive shock? Pathophysiologically, there's an increase in the immune response. Very good. So what happens? The immune system is stimulated. And pathophysiologically, what happens to your patient in anaphylaxis? They release histamine. Yes, we have an allergic reaction, but we have vasodilation. We have vasodilation as a result of that, of the chemical mediators. We have vasodilation, and that's what happens in, hence epi. That's why I need epi, right? Because I'm vasodilated. And so if I'm vasodilated, so anaphylaxis is one of what I call the double whammies, right? So anaphylaxis is vasodilation. So I theoretically have enough volume, but my space is larger, right? So what happens to my blood pressure? What happens to my flow? It goes way down, right? It decreases. And so then it causes this, right? It causes me to have agitation, confusion, because now I'm becoming hypoxic, right? Because I have a lower blood flow, and it causes things to happen to my vital organs. So let's see, I'm gonna save my next thought for something else, because in the anaphylaxis, I told you that, well, maybe I'll say it now. In anaphylaxis, I told you it's a double whammy. So we have vasodilation, but what also happens in anaphylaxis? What happens because of the release of the vasomediators? What do they increase? Capillary permeability, right? So fluid is going to move from the vascular space to the interstitium. That's why we have swollen eyes. That's why we have a swollen tongue. That's why we have hives and things like that. So it's a double whammy. So not only do we have vasodilation, we also have increased capillary permeability, and fluid is going to move out of the vascular space. So it's already, that vascular space is already dilated. Now some of that plasma volume is going to move out into the interstitium. And so that's why I call it a double whammy, because it's not only vasodilation and anaphylaxis, but it's also volume. Does that make sense to you? Yeah. Okay, so it's what I call the double whammy. All right, so anaphylaxis is, it's an acute situation, and I think that anytime, if you've given medications already in clinical, for me anyway, anytime I prescribe, have ever given a medication, it's a thing that's always in the back of my mind. Is my patient going to react to this medication, or is it going to, and it's not only medications, I have a whole bunch of things right here, but when we're talking about do you guys remember hypersensitivity reactions from J1 or J2? Do you remember talking about those things? Do you remember talking about hypersensitivity reactions though? There's different grades of them. This is a type 1 IgE mediated hypersensitivity reaction. And so like, if you've ever gotten in poison ivy, for example, you might break out in hives, or any other allergic situation that might be going on. But this is the granddaddy of them all, right? This can actually, it can actually kill you. It's life-threatening. So you're allergic to you're sensitized and you're allergic to something. So a lot of people think that, okay, well, I've never understood this, but let's say that you're going to go home for 6 weeks and take an antibiotic, that the home health nurse is coming to give you an antibiotic. But your first dose must always be given in the infusion center inside of a facility, because they want to make sure that you don't have anaphylaxis. So does anaphylaxis only occur, or hypersensitivity or an allergic reaction only occur at your first exposure? Absolutely not. So it could be your first dose, it could be your 100th dose. We just don't know what it is, okay? We don't know what it is. So it can be a drug, a medication, and I'm always thinking about antibiotics. It could also be any kind of a chemical. It can be a vaccine. That's why when you get a flu vaccine, aren't you asked if you are allergic to eggs, for example? Certain foods, and when I think about it, I think about peanut butter, how allergic many people are to peanut butter, for example. It could be an insect venom. It could be anything. But that in anaphylaxis, it's moving through the shock state and to the point of respiratory compromise, bronchospasm, laryngeal spasm, and circulatory failure. Okay, so circulatory failure happens because we have massive vasodilation of those vessels, and we also are losing volume. So it's that double whammy type thing. So I think many of you said that you know what the treatment is for it. And we'll talk a little bit about what the treatment is with these patients, but they're going to, and so patients that have atopic illnesses like eczema, allergies, which here is labeled as hay fever, but seasonal allergies, they are more susceptible to being asthmatics. So risk factors are anybody who are in this category here. People, if you have a family history of allergy or anaphylaxis to something. So that's why if you ever have a patient that's allergic to penicillin, they'll ask you, sometimes people will say, it's in my family. So you'll see that sometimes family members will be allergic to certain things like sulfa or penicillin or things like that. Some people have a latex associated allergy. So we always need to make sure that if we have a patient that has a latex allergy, that we don't use anything, and it's not just gloves. So people that have spina bifida have a higher propensity for latex allergy, for example, and certain medications such as beta blockers. And we definitely know that we have to be very careful with using beta blockers in patients who have asthma. So anaphylaxis. Has anybody ever seen anaphylaxis before? It is a scary, scary, scary thing. No, yeah. Hopefully you're able to recognize it before it happens. That's the most, really important thing is doing your homework, asking your patients for allergies. That's why it's super important to be paying attention when you're giving medications to people and prescribing them what they might be allergic to. Usually this is a sudden onset. And when it's ever happened to me, you know, your patients will, not to me personally, but that I've been caring for, they usually have this sense of impending doom. They just become very, very anxious. Sometimes they will become confused. They will start with this little cough. They'll start coughing. Then you'll start seeing the swelling. It can be their whole face. It can be their eyes. It can be their lips. It can be their tongue. They a lot of times will tell you that the back of their throat is itching. Then they begin with tachycardia. They might have some chest tightness or chest pain. And then, of course, once they start with the coughing, they also have some pulmonary edema. They'll start wheezing as well. They can have a laryngeal spasm. They can have edema. They can have stridor before that larynx actually closes. They can have a bronchospasm. Their skin can become very red, very blotchy, very itchy. They can develop hives. You guys know what hives are, right? Yes. What's the medical term for hives? What would you chart that you saw in the patient's skin? Urticaria is itching, right? Don't they form wheals? Don't they form wheals? And they can also have abdominal symptoms too. Pruritus is itching. Okay, so they form wheals. Okay, that's what that is. Okay, so these patients very, 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 very quickly can end up in respiratory distress, which will quickly progress to respiratory failure. And always our biggest concern is that they'll have laryngeal edema, and it's very, very difficult to intubate somebody who has a laryngeal spasm, has a bronchospasm, has cardiovascular collapse because of vasodilation and because of the movement of fluid. So we need to be very, very on top of it. So you want to support these patients very quickly. So our first strategy is always going to be prevention. Sometimes we can't help it. Sometimes we just don't know, right? And it's going to happen. So the first drug of choice is, somebody already said, epinephrine. Because what does epinephrine do? What is its function? What does it do? What does epinephrine do? It's a vasoconstrictor, right? So our vessel is vasodilated. So epinephrine, which is a catecholamine, right? It'll help breathe. Yeah, it'll improve that as well. But it's going to support blood pressure. It's going to cause vasoconstriction. And then we can use diphenhydramine. What class of medication is diphenhydramine? It's an antihistamine, right? So it causes, so we have peripheral vasoconstriction and bronchodilation. That's going to oppose the histamine that's being secreted, okay? So sometimes we can also use aerosolized epinephrine as well, which we would do to treat laryngeal edema. And then we also can use the H2 blockers like ranitidine, for example, which is also Zantac. So a lot of times when patients have a hypersensitivity reaction, you'll see that they get all of these drug classes because they do different things for this patient. So you'll always want to maintain a patent airway. That's the biggest concern that we have with, anaphylaxis, right? That we won't be able to support the respiratory system, and we'll have cardiovascular collapse. So we're going to nebulize bronchodilators. What's a medication that we would use for bronchodilation? Nebulized? Albuterol. Yep, that's a potent bronchodilator. We can use aerosolized epi, and then we probably, are, if we can get a tube down, we'll use an ET tube, an endotracheal tube, to put them on the ventilator to support ventilation. And if you can't, you'll have to go in through the cricothyroidotomy to create a space there to ventilate these kind of patients. Okay, if things get that bad, but hopefully, that's why people who have severe allergies and are at risk for anaphylaxis, they carry an EpiPen with them. And at some point in our history, and I don't think it's true anymore, epinephrine EpiPens were so cost prohibitive that people were not able to carry them. But I think that there's been some changes in legislation for those type of medications that now people are able to get them. Are you guys aware of that? Still expensive though. Okay. All right, this is correct. You have one. Okay. So yeah, so it's really sad. Things that are life-saving, like insulin and like epinephrine, that it's so cost prohibitive that people can't purchase them. That's just beyond comprehension for me. So when we're managing anaphylaxis, of course, we're going to do aggressive fluid replacement, because remember, we got that histamine release that's going to cause fluid to move out of the vascular space into the interstitium. So we need to replace that volume. We're going to give IV corticosteroids if the patient has significant hypotension that lasts greater than 1 to 2 hours after aggressive therapy. Okay, so now let's move on. Any questions about what we've covered so far? Sorry, I forgot to ask. Okay, no questions. I'm glad to see that you guys are really thinking. So the next distributive shock state we're going to talk about is sepsis. And remember, distributive, we're talking about vasodilation. So we hear lots of different terms, right? We hear the patient is septic. We hear severe sepsis, and then we're talking about septic shock, where we have hypotension, even though we're fluid resuscitating them. And as a result of that, we have hypoperfusion and hypoxia at that cellular level. We know that sepsis is usually related to some kind of an organism, usually a bacteria, either gram-negative or gram-positive, but it also can be caused from other things like viruses, funguses, parasites, all those things in that category. And a lot of times we're trying to always, not a lot of times, all of the time, we are trying to identify that causative agent. What is the thing that's causing sepsis? What's the thing that's going to lead to septic shock? But there is a small percentage, 30% or less, where we never identify what that organism is, okay? So it's an infection, yeah, but we don't know, sometimes we don't know what the causative agent is. Is that what kind of bacteria is it? So I don't know what happened to this slide, but it looks terrible. So we know that in shock, boy, where did this slide come from? We know that there's going to be hypotension despite fluid resuscitation, and there's inadequate tissue perfusion that results in hypoxia at the cellular level, okay? And then, of course, it's going to continue. So in septic shock, I want you to be thinking about who's at risk for it. So, and all the time, in anything that we do, you need to be thinking about the extremes of age. And the extremes of age are the very young and the very old. And so how do you think that somebody that is very old, how are they going to handle, how's their body, what reserve do they have? How are they going to be able to compensate for things like septic shock? And it's the same thing in the very young. So give me some patient categories or disease processes where the patient might be immunocompromised. And we're going to be talking about a lot of these in our cancer patients for sure, and cancer patients just in and of itself, and especially patients that are on treatment like chemotherapy or radiation, diabetics, chronic illness, ALS, anybody with chronic illness, people that have autoimmune disease, right? Lou Gehrig's disease is ALS, is Lou Gehrig's. Lupus is an autoimmune disease. What else? What about your patients that have HIV or AIDS? Are they immunocompromised? What about your patients that received an organ transplant? What about your patients that are on certain medications? What medications besides chemotherapy might your patients be on that cause them to be immunocompromised? A lot of patients in the United States, steroids, and more steroids, okay? So steroids cause immunosuppression as well. So think about your categories of patients who might be, just by their disease process or by their treatment, might be immunocompromised. So when we're talking, what does immunocompromised mean anyway? What does that mean? They have a greater propensity to be sick. Carrot, that's correct. Their immune system is suppressed to a point where, when I think about this immune system, I'm thinking about the army. The army is on high alert, and all day long it's going around the body looking for things that don't belong there and are sequestering them and getting rid of them, right? But if my army in this situation, an immunocompromised patient, my army is not at high alert. I might only have half my army available to me, or less than half. So that puts me at very, very high risk. And these patients are in a very different category. So your malnourished patients, who might be malnourished? I'm definitely not malnourished. But who might be malnourished? Your older patients, for sure. Your geriatric patients. Ooh, I hope not, but they might be. I hope not, though. Think about your adults. Who might be malnourished? The homeless, for sure. Very good observation, homeless. What about your alcoholic? What about your patients who have addiction? Do you think that they prefer to drink and do some kind of drugs? They prefer to do that for eating, right? Your anorexics, Abigail, very good. Think about the type of patient who might be malnourished. Your patients who have chronic disease, your patients who have cancer. Think about diseases that cause you, autoimmune disease, that cause you not to be very hungry, okay? People who don't have a spleen, they're also at risk. People that use chronic antibiotics, and then any insult, shock, trauma, burns. Pancreatitis is a great one, okay? That can cause shock. So have you guys, when you're in the hospital, have you seen like a great push for patients who maybe have come out of surgery or are coming up from the ED, for them to get their Foley catheters removed quickly? Yes, there's a huge push for that, right? So we don't want any catheter, any indwelling catheter, whether that's central line, a CODI, very good. We don't want a hospital-acquired infection. We don't want these patients. And the biggest push happened when insurance said, hey, if your patient gets a hospital-acquired infection, we're gonna decrease your reimbursement. So that's kind of sparked this movement. But in the old days, when a patient went to surgery, the first thing that happened once they got intubated was they got a Foley catheter. That ain't happening today. Unless it's a really, really long surgery, people are not getting Foley catheters. So Foley catheters are coming out really fast. In any other kind of indwelling catheter, if it doesn't need to be there, it's going to be removed. And also I want, in this category, I also want you to think about your surgical patients or anybody that has broken skin barrier. We don't talk about skin, but skin is our largest organ of the body, and it protects us. And whenever we have a breach in that barrier, this is where bacteria can enter, viruses can enter, parasites, fungus, whatever can enter. So these are the people that are going to be at risk for septic shock. Now, septic shock, your patho flow sheet here is not as pretty as your other ones, okay? It's not as pretty because there's a lot of other little moving parts. So take a look at some of these things so that you understand what's happening. And here we talk about peripheral vasodilation, increased permeable capillary permeability, embolism, maldistribution of blood volume, cellular oxygen supply. Everything comes down to this: decrease in cellular oxygen supply. When that happens, we have a switch in metabolism, we have a decrease in tissue perfusion, and we have impaired cellular metabolism. So take a look at the patho for this particular shock state. All of them, actually. Okay, so what do we have? We have microorganism invasion, which is going to spark that immune response. And we're going to have vasodilation with increased capillary permeability. We're going to have the release of platelet aggregation factor. So that's how we get those microclots. Because those when we have a release of the platelet aggregation factor, it's going to form the microvascular clots or from platelets. So we're going to have a thrombocytopenia in this particular situation. And then your patient will end up in DIC as well. And so when we have the TNF or the interleukin-1 that's released, that is going to cause us to have a myocardial dysfunction. So we're going to have a decrease in our overall ejection fraction. Okay. What else do I want to tell you about this slide? I think that's probably it. These patients are going to have vasodilation, maldistribution of blood flow again, myocardial dysfunction, a decrease in ejection fraction, and ventricular dilation. That's what's going to happen to them. Okay. What else? So what will your patients look like? The patients will initially begin with hyperventilation because it is a compensatory mechanism, because they're going to have some respiratory they're going to be in an acidotic state, right? And your patients eventually will have a decrease in urine output because of the maldistribution of flow. Of course, the same thing's going to happen to every patient. They're going to have an altered neural status, GI dysfunction. So remember that the GI system is one of those non-vital organs that doesn't get enough blood flow. So the GI system is going to quiet down, right? We're going to go we're going to have a decrease in peristalsis. We can also end up with GI bleeding. We can have a paralytic ileus. What in the hospital have you guys seen for patients who enter into the hospital? They're on some kind of GI prophylaxis. Do you know what that is? Every hospital is different. It just depends on what their formulary is. But they usually get something to protect their gut, right? Because they're under stress. They might get some protonics, or they might get Pepsid. It just depends on each hospital. But most patients are on some kind of prophylaxis to prevent a GI bleed, because it is a very stressful event. Let's see, when your patient isn't able to compensate once they are in shock and they can't compensate anymore, of course they're going to have respiratory acidosis, which is going to lead to respiratory failure. And of course, these patients have to be mechanically ventilated. Usually you'll see that they're mechanically ventilated. So this is, so we know that we'll see changes in their CBC. What are some of the things that you're going to see in that CBC? Complete blood count. What changes will you see in the CBC? You can see a high white blood count, right? Leukocytosis. If it's really overwhelming, a lot of times you'll see a drop in the white blood count, but for the most part, it's going to be an increase in the white blood count. What else will happen on that CBC? Sometimes you can see a shift in your differential. You'll see that your patients will be putting out immature cells, which are in the form of bands. You'll see that on your differential. You'll also see a decrease in the platelet count because you'll see a left shift. That's for sure. You'll see a left shift, and your patient, the platelet count will drop because of those microclot formations that are going to happen in these patients. Who knows what a CRP is? The C-reactive protein. What do we use? Why do we use that marker? It gives us insight into inflammation. It's a non-specific marker. Some people, in the old days, we used to use ESR, greater than 10, erythrocyte sedimentation rate, ESR. Some people still use that, but CRP is the newer one on the market, and it's a non-specific inflammatory marker. So it tells us, as Mo said, how much inflammation do we have going on in the body. And so as we begin treatment, what theoretically should happen to that CRP? So when the patient is septic, the CRP marker should be high. But once we start treatment, what should happen to that CRP marker? What's our goal? Well, if once I start antibiotics, for example, what should happen to my CRP? It should start coming down. So you're going to see that every couple of days a CRP is going to be drawn, because that is an evaluation tool. CRP is evaluation. It tells us, it gives us insight into whether or not our treatment is working or not. Procalcitonin is one that you might not know, and it's one of the newer markers on the market that we're using for sepsis, and it's for early detection of systemic bacterial infections. That's why calcitonin is being used. And of course, we already talked about lactic acid. We know that the lactic acid will be through the roof. It'll be greater than 4. Glucose levels, will they be up or down? They will be up. In response to what? In response to what? In response to stress, right? Because your liver, procalcitonin for antibiotic use. What do you mean? I don't understand that question. Will you tell me?
Is it used to check the effectiveness of antibiotics?
Do I use it? Oh, the effectiveness. It's it's kind of usually it's of course, again, the procalcitonin is non-specific, right? But it's a biomarker for early detection. So if we're going to monitor inflammation, we usually use the CRP for that. Does that make sense to you? Precursor for calcitonin. Yes. Okay. Yes. Okay. Good question. Great question. Blood cultures. What do we use? Why do we draw blood culture? What are we trying to find? The bacteria, right? How many days does it take for a blood culture report to be reported as final? How many days? How many days does it take for a blood culture report to be reported at final report? 1, 2, or 3? 1, 2, or 3, 72 hours, okay? So let me explain that to you, because this is an important piece and you guys all need to know what this is, okay? So a blood culture is going to identify your organism. On day 1, your microbiology department, they'll tell you on day 1, there's growth or there's no growth. On day 2, they'll tell you if there's growth, they'll tell you what that organism looked like. Maybe it's gram-positive clusters and cocci in clusters, for example. They'll tell you what it looks like. And if you remember anything from micro, if you know what the organism looks like, you can say, oh, that's probably this organism. On day number 3, they're going to give you the identification of the organism. Okay, does that make sense to you? Why is that important? Of course, we need to know what the organism is, right? That's causing the sepsis. But what's the overall bigger picture? Why do we need to know what that organism is? We know the patient's septic. Antibiotic effectiveness. So how is that going to, Mo, how is your identification of the organism going to translate to antibiotic effectiveness?
So for gram-positive, you have to use certain antibiotics. For gram-negative, you have to use certain antibiotics. So usually they want to start with a general antibiotic use, then eventually they target it to the specific bacteria after that.
Very good. So remember that your report is going to identify your organism, and below you're going to have that sensitivity report, right? On the sensitivity report, it's going to tell you whether your antibiotic is sensitive, if your organism is sensitive to an antibiotic, whether there's intermediate sensitivity or whether it's resistant. And as the nurse, it's important for you to know that, because if your patient has an organism and you're giving an antibiotic that organism is resistant to, are you helping the patient at all? No, you're not. Okay, so it's just as important for the provider to know what the organism is and what that organism is sensitive to. It's just as important that you know it as well, because if you're giving an antibiotic to a patient who is resistant to that antibiotic, is your patient going to get better or are they going to get worse? Yeah, they're going to get worse, right? You're giving them something that's not going to work. So blood cultures are super duper important. So when do you collect the blood cultures? At what point when you're taking care of a patient do you collect those blood cultures? Before or after you give antibiotics? Before, always before. So look, guys, if you give the antibiotic first before collecting any cultures, you are decreasing the amount of bacteria that is in the bloodstream or in the bladder or in the throat, anywhere that you're collecting a culture from. You're decreasing that count. So it may or may not be picked up in micro, because you've altered the count of bacteria. So make sure that you always get your blood cultures first. All right, that's an important pearl right there. So what will happen to your renal system in your patient with shock? What will happen to your BUN and creatinine? It's going to increase. They're both going to increase, right? So remember, creatinine is the toxin. So it's going to increase, and you're going to have a decrease in urine output. That's correct. And what will happen to your liver enzymes? The liver is a hugely important organ. It detoxifies the body. It does all kinds of other things too. They're going to go up, all right? So what are we talking about? What are the 2 liver enzymes that I want you to know that are going to go up? What 2 liver enzymes? AST and ALT, they're specific to liver, okay? So very good. So they're going to go up. And then I think Mo said DIC. So you're going to get a DIC panel as well. And you're going to see a change in your coagulation markers, because that's a huge risk for your patient that's septic, is that they will go into DIC. And if they go into DIC, what's the greatest risk of DIC? Bleeding, yep, bleeding, hemorrhage. So then we got all kinds of other issues associated with that, okay? So very good, very good. So how are we gonna manage these patients? Definitely we're gonna fluid replace them. So have you noticed that we said we're gonna fluid replace sepsis, we're gonna fluid replace hypovolemia, and we're gonna fluid replace anaphylaxis. Did we say we were gonna fluid replace cardiogenic? No. Okay. In fact, we said we were going to give them a diuretic, right? So the three states that we're going to fluid resuscitate to restore perfusion are the three I just mentioned: hypovolemia, anaphylaxis, and septic shock. Okay. In these patients, we're going to need a vasopressor or vasopressor. Who can tell me what vasopressor we might use? What vasopressors have you read about? Well, first, remember, I also told you that we had to fluid resuscitate before we could ever, yeah, Levo is a good one. Anything that's a vasoconstrictor, right? So remember that we always have to replace the volume first. Neo is usually the go-to. Fluid replacement always first, because you have to have something in the vessel to press. If you haven't resuscitated, your vasopressor will not work. Does everybody understand that point? We've talked about that twice. It's really important. You've got to correct the fluid volume status before you can press it. So we usually replace 30 to 50 milliliters per kilo of any isotonic fluid, which is lactated ringers or normal saline. All right. So don't forget that, because we want to increase cardiac output, we want to increase stroke volume, and we want to increase perfusion. Vasopressors, vasopressin, we can use vasopressin if our patient is not responsive to any kind of a pressor. All right, so our first drug of choice is norepinephrine, norepi. Okay. IV corticosteroids for patients who can't maintain adequate blood pressure with a vasopressor, despite fluid resuscitation. We love to give corticosteroids for those patients. And remember, if we give corticosteroids in a patient that's septic, what happens to their immune system? Just be thinking about that. So if my immune system is depressed, it's further depressed by corticosteroids, we just really have a double whammy here. But we also have to maintain blood pressure for perfusion. So antibiotics should be started with within the first hour after cultures are obtained. So we think about blood cultures all the time, but don't forget about the other cultures. And a lot of times, if we don't know where this is coming from, we're going to culture everything, okay? Everything: sputum, blood, urine, definitely urine, stool if you can get it, or if there's a wound, you definitely want to culture that wound. So I think that Mo said this. So before you get the culture report, it's going to take 3 days. You don't wait 3 days to start antibiotics. You're going to start antibiotics right away, and you're going to give something that's broad spectrum. It's going to cover a lot of things: gram positive, gram negatives, sometimes atypical bacterias. It's going to cover that. And then once you get your culture report and your sensitivity, then you can narrow down your antibiotics. All right, you can narrow it down. So that's why it's super important on day one to give something that's very broad. And once you get your report, then you can start narrowing things down based on whatever the identification of that organism is. So, so we know that the blood glucose levels, we want to keep them less than 180. In these patients, we don't want to tightly increase or tightly control their glucose, because we know that tightly controlling glucose in these patients can increase their mortality. And so we want to also give them a proton pump inhibitor, like we talked about, pantoprazole, which is Protonix, and we also want to do deep vein thrombosis prophylaxis, which is Lovenox, and some of you are enoxaparin, and somebody talked about SCDs. This is another place that you would want to be using SCDs. Okay, now let's talk, now we've talked about the 4 stages of shock that were, the 4 different types of shock, I should say. So we talked about hypovolemia, cardiogenic, anaphylactic, and septic. Now we're going to talk about each stage of shock. And this is going to go for all of the stages. So we know that the first stage of shock is the initial stage. And some of you may know that may or may not know that there's 4 stages of shock, and it depends on what school you go to. It also depends on what author. A lot of times people name these differently, and a lot of times they don't include the initial stage of shock. So they're overlapping. It's not like, okay, you can say this is the defining criteria for, initial stage versus compensatory. A lot of times they overlap each other. So in the initial stage, we're going to talk a little bit about that in a minute, but we know that that's when that insult occurs and when the body is making its first changes. So we know that in shock, what we talked about before is that there's a decrease, our umbrella is a decrease in tissue perfusion as a result of a decrease in cardiac output, a decrease in stroke volume, where the cells become hypoxic. There's a mismatch between what is needed and what is available. And if we don't fix our patient, what will eventually happen is they'll go into multi-organ system failure or dysfunction, and eventually it can lead to death if we aren't able to recognize it. And many of you might be thinking to yourselves, well, I don't really need to know this because I don't plan on working in the unit. So I don't need to really know this stuff because I'm not going to work in ICU. I'm going to work in labor and delivery or whatever. But you do need to know that. A few weeks ago, I got a patient on my service who was transferred from one hospital within a network to where I was that particular day. And that patient had been on a med-surg unit and was in, I think, septic shock. And they didn't recognize that the patient was in septic shock. The patient came to ICU, and eventually the patient died. Because the patient was already, moving so quickly, and he was an elderly man, and I don't remember his underlying disease processes, but he ended up dying because nobody recognized that this guy was going into shock. By the time that he came to my facility where I was on call that day, he was already in full-blown shock, okay? So in the initial stage, this is when the insult has already occurred. Whatever that insult is, a bacteria, a fungus, a parasite, or whatever the situation is, whether it's hypovolemia or what have you, the insult has already occurred and the body is making changes at that cellular level, because remember that the body always wants to maintain homeostasis. So it's going to use its neighbors. It's going to rely on its neighbors for that compensatory mechanisms to support whatever's going on. And so we know that there's a tissue perfusion issue. There's a decrease in cardiac output, and the cells are hypoxic. So at the cellular level, the cells are not getting enough oxygen and nutrition. So how do they correct it? They change their metabolism from aerobic to anaerobic metabolism in order to maintain life. Otherwise, the cells begin to die. And so that's what they're doing to compensate. And as a result of that, what is the byproduct that happens because of that change in metabolism? lactic acid production, right? So then we have a change in the pH of our blood as a result. So then we change. So what kind of pH change will we have in our blood if we have lactic acidosis buildup? It'll be, our pH will drop. So Mo, will we have a respiratory or will we have a metabolic acidosis? Yeah. If we have pH, I want you to think about that. Will we have will we have a respiratory acidosis or will we have a metabolic? We have a metabolic acidosis, right? We'll have a metabolic acidosis. So, so in this particular phase, the insult has already occurred. We have changes happening at the cellular level. You, the nurse, are you going to actually be able to see this state? Are you going to actually be able to recognize this state? How are you going to know, Mo? How will you know in this initial stage?
Well, their blood report will come up with them having like an acidic in their blood, and that would be like a first instant knowing that something is up. It might not be as high as 4, but it'll be high enough for you to figure there is some change going on. So at that point, you want to start maybe fluids and Lasix to kind of wash out the lactic acid out of the system.
Okay, so, and that's just, that would just be, that would be by pure luck, that if you just had a piece of data, right, that showed you on your lab results. Most of the time in the initial stage, when all the cellular compensations begin, we don't recognize it. There might be some subtle changes in vital signs. If you're being an astute nurse and paying attention to vital signs, there might be some subtle changes there. But in the initial phases, as the nurse, we usually don't know that this is actually happening to our patient, okay? Just so you know, the initial things are things that we're not gonna know. So the thing that I told you earlier that I want you to always be aware of is your ongoing assessment. And you need to know what normal is. What is a normal neurological status? Awake, alert, oriented times 4. Knows where they are, knows who they are, knows what the situation that's going on, okay? So if you know that and you see a change in your patient, maybe they've become very anxious, maybe they become a little bit on the confused side, and they weren't that way when you came on your shift today, those are things you need to be paying attention to. What has happened cardiovascular wise? What are the changes in their vital sign trends? So what is the change? What have you been seeing, and what are you seeing now for blood pressure, heart rate, peripheral pulses, capillary refill? Those are the kinds of things I'm thinking about. So remember that you, the nurse, are always responsible for those vital signs. And the thing that you're always, not that you're not looking at what's happening at this particular moment in time, you're also looking at what happened in the past if you have that data, all right? Do I see a change in vital signs? And how drastic is that? Also, what is normal with regard to respiratory status? What is my normal respiratory rate, for example? What do I expect to happen in the urinary system with regard to amount and color and specific gravity and things like that? What is normal for skin assessment? What is versus abnormal? What happens in strength? What happens with your ABGs from normal to abnormal? Those are the kinds of assessment things you need to be thinking about as you go through the stages of shock. So what happens, your body has that initial shock, or that initial insult, I should say. It's trying to compensate. It's changing from aerobic to anaerobic, and then this is the phase, the stage that you, the nurse, are going to be more than likely be able to see or detect, if you will, because now your body has a mismatch between the amount of oxygen that it needs and the amount of oxygen that is available. So there's an imbalance there. And so when that happens, when there's an imbalance and when there's hypoxia, for example, our baroreceptors in the aortic and the carotid sinuses, they are going to be activated. The baroreceptors and the chemoreceptors are going to be activated, and they're going to sense that there is a change in blood pressure, for example. And so they're going to be stimulated. And once they're stimulated, they're going to increase heart rate, right? They're going to increase heart rate, because we're going to have some vasoconstriction that goes on, because when all of this process begins, there's going to be a cascade of events that happens to combat that anaerobic state. It's going to, the cascade of events that are going to be neural, hormonal, and biochemical, their job is to increase cardiac output, increase blood pressure, and improve perfusion. So biochemically, we're going to stimulate what are the things that are going to be secreted from the sympathetic nervous system? What's going to be secreted? Yes, absolutely, right? So epinephrine and norepinephrine, because that is going to, what does epi and norepi do? What do they do for the body? They're going to cause, that's fight or flight, but what are they going to, if that is right, it's adrenaline, right? But pathophysiologically, what is epi and norepi going to do? Think about vasoconstrict. It's going to vasoconstrict to increase blood pressure, right? That's what's going to happen. And then Mo also said we're going to stimulate the RAS system, the renin, angiotensin, aldosterone system that nobody wants to talk about, right? Nobody likes that. What does the RAS system do? What does it help us do? To increase cardiac output and increase perfusion. What does the RAS system do? Tell it. It increases blood pressure. So it's going to convert angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor, right? And as a result of that, it's going to increase our blood pressure. So what about aldosterone? What does aldosterone do? Doesn't aldosterone help us hang on to sodium and water to increase blood pressure? Yes, it keeps salt and water, and it increases our volume, which in turn increases our blood pressure. And then the posterior pituitary gland is going to secrete antidiuretic hormone, which is going to help us also hang on to some water so that we can increase our blood pressure. So there's a lot of chemical mediators that are happening here. The body is trying to save itself, all right? So it's trying to overcome some of the consequences of this mismatch that we are experiencing. So that is what's happening here. So we're going to see an increase in heart rate, right? So what will happen to blood pressure? This is compensatory. So we're hanging on to water. We're hanging on to sodium. We have vasoconstriction. What will happen to blood pressure? It's going to stay normal or increase, right? It's going to be normal to increase because the body says, hey, I need some help here. So all of these neural, hormonal, and biochemical things that are happening in places that you and I can't see, the body's trying to fix itself. So heart rate's going to come up. And if all things are working, blood pressure should stay normal or increase slightly, okay? Or increase slightly. Does that make sense to you? Or is it mud? It's compensatory. The body's able to compensate, but that doesn't mean that you and I don't need to help. That doesn't mean that medicine doesn't need to come in and help, because we do need to help, because these compensatory mechanisms, as we talked about last week, they're short-lived, right? So we need to come in and fix the problem, identify what is the offending organism, what's causing the hypovolemia, what is the stimulus for anaphylaxis, for example. We need to fix, we need to fluid resuscitate if that's a situation, or we need to reperfuse the cardiovascular system. So we have to come in and identify that and try to fix it. So here's the pathoflow, which comes, I believe I got this right out of Lewis, but this is pretty complex here. So here are the stages of, and I already talked to you completely about this, how the baroreceptors stimulate the sympathetic nervous system in response to a low blood pressure. We get vasoconstriction. I've already talked to you about all of these kinds of things, all right? So we talked about what happens in the GI tract, what happens to the skin, what happens in the kidneys. Okay, so if the cause of shock is corrected, people usually recover from this stage without any type of residual effect. And remember that that's always our goal. Our goal is to return them to at least the state that they were in before this insult occurred. So we want them to leave fully recovered with little or no residual effects. So if we don't recognize, if we don't correct, that's when patients will move from compensatory to progressive. Now, once we get to progressive, of course, that's a very serious, not that all of them aren't serious, but this is a very serious stage of shock. And this is when we haven't made any corrections, we didn't recognize, and now these compensatory mechanisms that we just talked about, they have failed. The body is out of reserves, and now we're going to progress to a multi-system organ failure, or MODS, okay? So what happens here is our cells begin to swell, we have capillary permeability, and so when we have capillary permeability and we have a decrease in protein, water is able to move out of the vascular system and into the interstitium. Do you get that, guys? Do you understand what I'm talking about here? So we're going to have a decrease in blood pressure. We're going to have a decrease in cerebral perfusion. We're going to have a decrease in peripheral pulses. We're going to have an increase in heart rate. We're going to have some renal tubule damage. We're going to have some acute kidney injury, if you will. Our urine output's going to drop. If we have increased capillary permeability, we're going to see pulmonary congestion. We're going to see that fluid leak in there. And what happens then, we're going to end up in pulmonary edema. We can have effects to the GI system. We can end up in DIC, and we can end up in multi-organ system failure. Now, in this situation, we still have an opportunity to fix our patient. And here's the pathoflow for that. You can see all of that. Let's see. So here is what I told you. We're going to have a leakage. So remember that when we have a low protein, that opens up that opens up the ability for fluid to shift. So you'll see it move from the intravascular to the interstitial space, and you'll see that we'll have systemic interstitial edema. So they'll be very fluid volume overloaded in the interstitium. They'll be very edematous. Sometimes they'll even have anasarca. Do you guys know what anasarca is? It's on my next slide. Edema. You know, I always call it the Michelin Man in my head. That's what I think about. They're just full of fluid. All right, so the fluid leakage affects not only the interstitium, but also the solid organs and the peripheral tissues. There's decreased blood flow to the capillaries. We have sustained hypoperfusion. So if that's the case, we're going to have very weak peripheral pulses. We could even have ischemia to the distal extremities, like the toes usually. We're going to have a decrease in capillary refill. It can be quite significant, okay? And the cardiovascular system can be really affected in the progressive stage of shock as well. So cardiac output is going to continue to fall. We're going to have a decrease in blood pressure. Your patient's going to be, at this phase, they're going to be intubated. They're going to be on all kinds of drips and pressors and trying to move that fluid. We're going to try to move that fluid because it's in the wrong space. Okay, it's in the wrong space. So what's my next slide here? This is the myocardial dysfunction. So we're going to see a lot of these patients will have dysrhythmias. They will, when they're acutely ill like this, they'll have some PVCs. They might have atrial fibrillation. We see a lot of atrial fibrillation in these kinds of patients. They're going to have some ischemia to that myocardial muscle. It might even be so profound that they end up having an acute myocardial infarction as a result of it. And then you know, as we progress through this system, it's going to be really, really hard to get them out of that. And of course, we're going to have what we already talked about, which is pulmonary edema, and all of the things that come with pulmonary edema, which we know is respiratory distress, which will eventually lead to a respiratory failure. And that's what this slide shows you here. Okay, this is what your patient will look like. They'll have cardiac and pulmonary dysfunction. We already know what's going to happen in the GI tract, right? We already know that it's going to slow down. They're going to be at a risk for GI bleed. Your kidneys are going to be hypoperfused, and when your kidneys do not like to be hypoperfused. So you're going to have an acute kidney injury, and you could even end up passing through, to a chronic situation. You have to be careful about what drugs you're giving these patients. Does it affect their kidneys? Because if you do, you could further damage their kidneys. We know that they'll have an increased BUN and serum creatinine, and they will have a metabolic acidosis. Your liver will also fail, okay? So we know that your AST, ALT, and bilirubin levels will be elevated. Remember that your liver plays a huge role in the production of clotting factors. So your patient is at risk for DIC and at risk for bleeding out or having a hemorrhage. They're also at risk for jaundice and a lot of other things as well, bacterial things. And then the last phase is the refractory. And refractory means that, we've done everything that we can to resuscitate you, to reverse the acidosis, to reverse the offending organism or, situation, and we've been unsuccessful. So we have an exacerbation of acidosis. We have an accumulation of lactic acid. We have increased permeability, capillary permeability, which would cause further leakage of fluid out of the intravascular space. And when that happens, we have failure of one organ system, which affects another. Remember that no organ system stands alone. So all of the organ systems do something to help one another, whether they secrete a hormone or whatever the case might be. Everything is predicated on another system. So you'll see that your patient will have profound hypoxia, profound hypotension despite the medications that you're giving. You're going to have several drips by this time. They're going to be ventilated. Their tachycardia is going to worsen. And this is a stage of no return, okay? There's no return from this stage. So this is an unmanageable state. It's the final stage of shock. And so your patient is going to have multi-organ system failure, and they're more than likely going to die in this phase. So tell me, what is going to be how is your nursing care going to change once you hit refractory? Comfort, yeah. So you're going to provide comfort for the patient. Where do you palliative care? Yeah, palliative care, making our patient comfortable, right? And what about family? What about the family? Active listening, being supportive, thinking about, and making sure that, they also are comfortable, making sure, yeah, care, your focus shifts to them for care and support. Yes, Abigail. And thinking about, how difficult that this is going to be because remember, the person in the bed is a patient to you, but the person in the bed, somebody loves them, okay? This is their loved one that they know is not coming home with them. So how would you care for them? What would you do for them? Okay. And how, I've seen some really ugly things where people are like, oh no, there's only 2 visitors. Well, if that's your mother, your brother, your dad, your husband, whatever the case might be, everybody wants to be there. So how are you going to handle that? Of course, it's going to be according to hospital policy, but I want you to be thinking about those kinds of things. Okay. And where your focus is going to shift. So I think that I'm going to stop today because, boy, we've done a lot here, okay? We've done a lot today. And if there's anything extra that I want to share with you guys, I will share that with you. If I go through, I have like, I don't know how many slides here, but I have 108. So, but there's some test your knowledge questions in the slide deck. So is there any questions? I know that we've been on here for probably 2 hours or more. I haven't yet, Racine, but I will do that very quickly. What works best for you guys on Friday, afternoon or morning? Afternoon. Got one afternoon, morning. Okay. Anybody else? Let me go to the chat. Okay. It looks to me like the mornings have it. Looks like so I will do it in the morning. I'll be in Florida on that day, so I'll be an hour ahead of you. So I will let you know. It'll probably be around this time on Friday, okay? You guys, I think you're doing a fabulous job, and thank you for coming. And I want you to stay dedicated to